Right. A very good afternoon. I hope all of you are doing well. So I hope I'm audible and visible to all of you. So after a long time, I've come back, and so today we are going to do a very important session. That is, we'll just recall the offline questions and we'll assess and understand what is a pattern of question. So I always tell you that obstetrics and gynecology is a highly scoring subject, and it's a very easy. So you don't require to never complicate obstetrics and gynecology because it's a very simple subject. It's only about uterus, right? So it's a very simple subject and it's always highly scoring. So you should be always having a very obgyn as a very strong subject, and same has been reflected today in the exam also. So whatever questions and options I've got is from the recall by the students. So they might not be, there might be some mistakes here and there. So you can correct me if there is any, if you feel that was not the same question which has come in the exam, right? So we'll, and most important, this is just a recall so that we'll understand and learn through this. But even if you have, if something you have gone wrong, don't be upset at all because you are going to do definitely very well, right? Very good afternoon to all of you. I'm also excited. After a long time I'm taking a class. So regarding the Unacademy has plus subscription as well as iconic subscription. So in the Unacademy platform, now you have raise a hand. That is, you can raise your hand and speak to us in a live session. That is something which is wonderful, right? So you have many sessions in the Unacademy, many batches in the Unacademy. So you can apply and you can use any personalized whatever suits you the best, right? You can use the code of Ramya Live for further discount, guys. So you can use the code of Ramya Live for further discount. Okay, let's start with the questions. Next question. What is the management of uterine septum? Now, if I remember, this is a repeat question, guys. This question has also been asked in NEET 2019. Management of uterine septum was also asked in 2019. Now, I don't know, there was some confusion regarding the options. So, if your options were laparoscopic resection of septum, hysteroscopic resection of septum, and uterine metroplasty, what is the best answer you have here? And what is the correct answer you have here? Very good, excellent, Ashish. So, the best answer or the correct answer here is hysteroscopic resection of the septum. So whenever you have septate uterus, septum is pointing towards the uterine cavity, right? Septate uterus, septum is pointing towards the uterine cavity. So what are you going to do? Now, how can you do laparoscopy? Laparoscopy means you have to approach through abdomen. But why will you approach through abdomen when septum is present inside the uterus? So as the septum is present inside the uterus, what are you going to do? You're going to go hysteroscopically, that is through uterine cavity, and this is called resectoscope, with the help of which you're going to remove the septum, right? Okay, so metroplasty was also given is what some of you are telling. If you had the option of hysteroscopic resection of the uterus, please go with resection of the septum. Okay. The answer here will go for hysteroscopic resection of the septum, or if they had option of hysteroscopic septoplasty, then also it is correct. So I don't know which option was there. So if you had hysteroscopic septoplasty, even that is also correct. Both are same. But if you had metroplasty is not the answer. What is metroplasty? Metroplasty is where you remove the medial half of the uterus and you do the unification surgery of the uterus. And where do you do metroplasty? Metroplasty is done for didelphys, Metroplasty will be done for didelphys and bicornuate uterus. Okay, so here what is the answer? If you had the option of hysteroscopic septoplasty, go with septoplasty because septoplasty and resection of septum both are same. Okay. So septoplasty means removing the uterine septum. Okay. Metroplasty means removing the medial half of the uterus and unifying the uterus. So metroplasty will be done for didelphys and bicornuate uterus, whereas septoplasty will be done for uterine septum. Okay. Right. So I hope there is a clarity on this. Now somebody was asking me that why do we have transverse lie in uterine didelphys? See, whenever this, why do we have malpresentations? One of the main reason for malpresentation is whenever the space in the uterus is compromised. So here uterine didelphys means you have two uterus. So the uterus can be smaller compared to a normal uterus. So as the space is compromised, you have more chances of them going into malpresentations. Even if you go back and look into your books, one of the obstetric problem associated with uterine malformation is malpresentation. So malpresentation can be transverse lie, or you can also have breach. Okay. Right. So I think there was one more question like this. Infertility patient USG suggestive of uterine anomaly. Best to confirm is. Best investigation to confirm is. So was there one more question like this? So indirectly they're asking you what is the best test to or gold standard test to confirm the uterine anomalies. Excellent. So this you're all answering correct. So this is something again here the gold standard for uterine anomaly is hysteroscopy and laparoscopy. The gold standard for uterine anomaly is hysteroscopy and laparoscopy, right? So investigation of choice is 3D USG, which they have already done, and gold standard for uterine anomaly is hysteroscopy and laparoscopy. So best to confirm is with hysteroscopy and laparoscopy. 3D USG bar MRI, but most important is the investigation of choice. 3D USG is more likely, right? Okay, even if you had the option of CECT, still your answer will go for hysteroscopy and laparoscopy itself, right? So please see there were almost 3 questions on uterine anomalies, and I think there was one more question also on the uterine anomaly. So this was one more question which I thought which students told me there was there. 4th question on uterine anomalies. You know, somebody who is very perfect with uterine anomalies, it is like a jackpot. 4 questions on uterine anomalies. So what is the modality of this test? This is one of my favorite image, and I always ask students whenever I conduct any test or even in my YouTube sessions, you could have seen this picture. But I ask usually the question that what is the diagnosis for this? But they were kind enough, they just asked you what is the modality of this test, right? So was the question correct? What is the modality of this test and how do you perform this test? So what is this image? So this image is nothing but hysterosalpingogram. Again in NEET 2017 also you got an HSG image. NEET 2019 also you got a HSG image, and this year also you got a HSG image. So HSG images are very important, right? Thank you, Dr. Casey. Yeah, even I have observed most questions from gynec. There were hardly 1 or 2 questions from OBS this time. So the modality of the test is nothing but HSG. Anybody would like to tell what is the diagnosis for this? What is the diagnosis for this? Modality is HSG. I agree with all of you. Okay, one more option was saline infusion sonography. Thank you, Dr. Rowe. Right. So most of you, actually, if they would have asked the diagnosis, then it would have been a googly and many of you would have gone wrong. So good they have asked what is the modality. So this looks like a unicornuate, but this is not a unicornuate test, guys. This is not a unicornuate. I'll just zoom it and show you. Unicornuate, you'll have only one horn and one fallopian tube, right? So if you closely observe, here you have, this is one cornu, this is one cornu. It is bilateral cornual block. It is bilateral cornual block. And this is nothing but a pseudo-unicornuate uterus. This is looking like a unicornuate because of the bilateral cornual block, but this is not a unicornuate. So this is called pseudo-unicornuate uterus. What is the condition where you see pseudo-unicornuate uterus? So which procedure? It is a HSG, right? So this is a pseudo-unicornuate uterus. And this is due to tuberculosis. So we are just being prepared for next, right? Okay. So this is nothing but this procedure is nothing but hysterosalpingography. Hysterosalpingography. Right. Next question. 6 weeks of amenorrhea. Left adnexal mass on USG. Beta HCG is 2500. No fetal heart rate. What is the management which you want to do? I want you people to answer and then I will start answering for this. So this is based on the criteria for the ectopic pregnancy, right? Thank you, Nandakishore. The size was also given, which is 3 centimeters in size. Excellent. That makes more sense. So the most important points when I have to decide what is the management for ectopic pregnancy, I consider these points. The size of the sac here is given 3 centimeters, right? Next point which I'll consider is FHR, where you don't have FHR, no FHR. Third point is beta HCG levels. Beta HCG levels is 2500. Now the question arises, and patient is hemodynamically stable. Very good. So patient is also hemodynamically stable. Now all these definitely rule out one thing for me, that is I don't require to go for surgical management here. I don't require to go for surgical management here. Okay. One option was milking of the tube. We don't do milking of the tube. Milking of tube is absolutely contraindicated, guys. Okay. So definitely that is not answer. Beta HCG was 2800. Okay, right. Now, I hope you all know, was it given single dose of methotrexate or multiple dose of methotrexate, guys? Milking of tube will not be the answer, but yes, that is one option. Okay. 24-year-old. Was she primary or multi? Okay, single dose. Right. Now let's go to the management. So this is the most recent guidelines which we also have learned. So if you see here, for many of you are answering expectant management. Expectant management when gestational sac is less than 3.5. Yes, here you can do expectant based on the gestational sac. For expectant management, your beta HCG should be less than 1000, guys. So you cannot do expectant management here because the beta HCG level is 2800. But when can you do expectant management? You can do expectant management only when beta HCG level is less than 1000. So expectant management is out of reach. This is gone. Okay. Next one. So when can you do medical management? When patient is having hemodynamically stable, sac size less than 3.5, no FHR, and beta HCG should be less than 1500. Or beta HCG can be between 1500 to 5000. Between 1500 to 5000, you can either do medical or surgical, guys. Between 1500 to 5000, you can either do medical or surgical. So it perfectly suits for medical management. Whatever the criteria they have given us, perfectly suits for medical management. So this table is very, very important, guys. So when can you do medical management? When sac size is less than 3.5 with no FHR, beta HCG is less than 1500, Patient is able to return come for follow-up, and patient is hemodynamically stable. So you mainly give single dose. Single dose methotrexate is always preferred over multiple dose. And what do? You give methotrexate 50 milligram per meter square, and then you have to check the beta HCG levels day 2, day 4 and day 7. Day 2, day 4 and day 7, right? So drop in 15% of beta HCG from previous value. She is responding. If there is less than 15% drop, you have to repeat. Now, when will you go for surgical management? If there is a significant pain, if the sac size is more than 3.5 with FHR, or if beta HCG level is more than 5,000. And the best method in surgical management is salpingectomy. Okay. When do you prefer salpingotomy or ostomy? When only one tube is there, you go for otomy and ostomy. Otomy and ostomy is not preferred because recurrence is high. And between 1500 to 5000, you can either go for medical or surgical. So it really doesn't matter if you tell me the beta HCG is 2800 or 2500 up to 5000. Now, why will the answer be methotrexate? That I will tell you here. So the answer here is single dose of methotrexate. Now I will tell you why the answer should be single dose of methotrexate, supporting it. So first point is that, once again, she is primigravida. So I want to save her tube, right? Next, sac size is only 3 centimeters. So I can 100% do medical management. There is no FHR and beta HCG level is less than 5,000 and patient is hemodynamically stable. So all this tells me that I have to go towards the single dose of methotrexate. Okay. So best answer will be single dose of methotrexate. I hope you're all clear with this. Okay. Next question. History of primary infertility, 2 fibroids in the cornu and both sides tubal blockage. Ovulation in the woman is normal and semen analysis is normal. How do you want to treat her? What is the treatment which you want to do for her? Yes, excellent. So all of you are answering correct. So here there are 2 cornual fibroids, guys. 2 cornual fibroids and both tubes are blocked. So even if I do myomectomy, will she get pregnant? She'll not get pregnant because both the tubes are blocked. So what is the best thing you can do is, you can, as she is already ovulating, you can pick up these ovums and go for IVF and do the implanting. You can implant it. So best is ART. ART is assisted reproductive technology, where you can go for IVF, IVF, ICSI, anything, right? So here the best thing is IVF. So that's why ART will be the best answer. There's no point in myomectomy because both tubes are blocked. So even if you do myomectomy also, she'll not get pregnant because both tubes are blocked, right? Was it intramural or was it so size of the fibroid is 2.5. There are almost 2.5 centimeters, 2 fibroids. So one more option was uterine artery embolization. Okay, so one more very important point here, guys. Whenever you have a patient coming to you with infertility, you should never do uterine artery embolization. Okay, so another was 7 centimeters. 7 centimeters is very huge. Did they give both sides tubal blockage also? Okay, based on what you are writing, my answer definitely changes, guys. So I can understand one thing. So one thing that you people are telling, it is not cornual fibroid. There are two intramural. Just give me 1 minute. I'll just frame this question again and write it. Primary infertility, two intramural fibroids of size 2.5 centimeters and 7 centimeters covering or blocking the ostia. Blocking the ostia. What is the management? If this was the question and options were ART, laparoscopic myomectomy, GnRH analogs, and uterine artery embolization. See, there is a very huge difference in tubal blockage and ostia getting blocked because of fibroid. If ostia is getting blocked because of fibroid, you have to remove the fibroid. And 7 centimeters fibroid is not a small thing. Even if you do IVF, it can't get implanted. If the question was this and uterine artery embolization, then your answer should go for laparoscopic myomectomy, guys. If the question was this, so that is why the framing of the question, is very important, and whatever questions you give, based on that we answer. So if the question was this, then you have to go for myomectomy. If it is an intramural, yes, if the question is this, then it is laparoscopic myomectomy. Okay, because previous question which I wrote, what I assumed was that there are two cornual fibroids and tubes are blocked. That is completely different. Okay, so if this is the question, it is laparoscopic myomectomy. Right, let's go to the next question, guys. Now please correct me in this also. Lady using OCP since 5 months, amenorrhea since last 6 weeks. What is the best way to calculate the gestational age in this case? Lady using OCP since 5 months. So as she has been using OCP since 5 months, she is already amenorrheic from 5 months. So she's using OCPs on 5 months, and now currently when she's on OCP, she has gone into amenorrhea from last 6 weeks. So you don't know when is her LMP. Right? So what is the best way to calculate the gestational age? So whenever we don't know the LMP, the best way to calculate the gestational age is CRL, by using the CRL with USG, right? Again, PPH is a very important topic, guys. So this is something which all of you should have answered correct. So the order of ligation for devascularization in PPH. So whenever we do stepwise uterine artery devascularization, right? So what do we do in stepwise uterine artery devascularization? First, near the incision, you block the uterine artery. So first what you block is uterine artery. Then even if the bleeding doesn't stop after blocking the uterine artery, but what do you do next? You're going to block the utero-ovarian anastomosis. So if they gave you ovarian artery as the next option, yes, your next option will be ovarian artery. If after blocking the utero-ovarian anastomosis, also if the bleeding continues, what do you do next? We all know that uterine artery is a branch of anterior division of internal iliac. So what are you going to do next is you're going to ligate the anterior division of internal iliac. So here the best answer, you will never block external iliac. So if you had an option of uterine artery, ovarian artery and internal iliac artery, go with this. External iliac though you will never block. If you block external iliac, she'll go into leg paralysis. Was there no question of internal iliac? Was there no option of internal? There was option of internal iliac, right? So I see Satish telling me that there is an option of uterine artery, ovarian artery and internal iliac. If this was there, this is your answer. Okay? Yes, I am coming to that question also, Khalid. Right. Patient with post-molar evacuation. Yes, I have put that OCP question also. Don't worry. Okay. Pregnant female with active herpetic lesions in the vulva, what is the management? Pregnant female with active herpetic lesions in the vulva, what is the management? Now again, this question also we have discussed in our free classes which I used to conduct. One of this question has been discussed and we have also given it in the TNDs. So Vaibhav, even if it is low risk or high risk, except stage 1, all other stages we go for EMACO. That's what I'm telling. Okay. Yes, excellent. So this here, as there is an active herpetic lesions, you have to give acyclovir. And whenever you have active herpetic lesion, it's an absolute indication for elective cesarean section. You should never conduct a vaginal delivery when there is an active herpetic lesion. Okay. So here the answer goes for acyclovir and elective cesarean section. Okay. Next, patient with infraumbilical flattening, fetal heart rate heard laterally. What is the presentation? So if you observe, this is the normal abdomen. So when occiput and back is toward occipito anterior and back is anterior, you get a proper bulge from above to down. But when you have occipito posterior, like in this picture, occiput is towards the posterior. So what happens is, here that the bulge due to occiput won't be there. So what are you seeing here? There will be infraumbilical flattening. And wherever is the back is present, there you will hear the fetal heart rate. So as the back is present posteriorly here, usually the fetal heart rate will be heard in the flanks in OP. Whereas where will you hear the fetal heart rate? In the OA? In OA, you hear in the spino-umbilical line. So you will hear the fetal heart rate in the spino-umbilical line. Okay. So infraumbilical flattening is very classical, and fetal heart rate heard laterally in the flanks is very classical for OP. Now coming to the breech. Breech, you don't have infraumbilical flattening, and next in breech the fetal heart rate will be heard around the umbilicus. Around the umbilicus. Transverse lie, right dorso-anterior is transverse lie. In transverse lie, lower pole will be empty. So you will not have any flattening. There will be empty. Lower pole will be empty. And there also you will hear around the umbilicus itself. Bro is almost like your occipito anterior. So fetal heart will be in the spino-umbilical line. Okay. So how do you diagnose OP? Lower part of the abdomen will be flattened, that is infraumbilical flattening, difficult to palpate the fetal back. Fetal limbs will be palpable anteriorly. Fetal heart rate will be heard in the flanks. Okay. So this is in your notes and the PPT which I provide. Posterior fontanelle will be towards the sacroiliac joint. Anterior fontanelle is easily felt. Only in this condition your anterior fontanelle will be easily felt. And you will have mark molding with extensive caput, right? Next question. Husband asks for paternal testing of his twins. One twin is found to be his son and other is not. Diagnosis. Now those who have heard my classes, I always tell that this is in Williams also they have given one picture where I thought of putting that picture actually, where one baby is of white race and one baby is of black race, and then they find out that it is of two different fathers. That is how they have come to this. I always tell you this story. So it is superfecundation. So superfecundation is when you have two ovums released in the same cycle, but two ovums are copulated with two different times of intercourse. So one has formed today, so probably the other one has been formed tomorrow, like that. So there is some time gap between. It need not be always a different partner, but when there is a different partner and twins, it is more likely to be superfecundation. So superfecundation is fertilization of two ovaries released at the same time by sperms released at intercourse on two different occasions. So fertilization of two ovas released at the same time by sperms released at the intercourse on two different occasions. So the two different occasions can be two different partners also, right? Superfetation is an interval as long or longer than a menstrual cycle intervenes between the fertilization. So superfetation is only theoretical. What does it they say is like this cycle one egg has been fertilized, next cycle another egg is fertilized, right? So this is not superfetation because superfetation is only theoretical. Superfecundation is the one where by two different partners, two twins being possible. Okay. Superfetation is only theoretical. We have not seen superfetation yet. Okay. Yes, excellent, Alimat. So it is not seen yet in the human beings. Right. Teenage pregnancy with transverse vaginal septum with dysmenorrhea and teenage patient with transverse vaginal septum with dysmenorrhea and chronic pelvic pain. Diagnosis is. Okay. Many of you have queries regarding the choriocarcinoma question. I'll come back to that question once again. Don't worry. Okay. So I have collected all the questions which you are putting there. So don't worry. So other options were dermoid cyst and thecal luteal cyst. Thank you. Good. Yeah, you people remember the options so well. Yes. So the most common complication which they had because of the transverse vaginal septum. Right. Now, what happens when there is a transverse vaginal septum? So usually transverse vaginal septum will be in the between the upper 2/3 and lower 1/3, right? So because of the transverse vaginal septum, what will happen? Okay, so there is some difficulty in this question. Excellent, Abe. Sham Sundar, correct. So because of the transverse vaginal, if there was a question like this, the answer will go for endometriosis. Why? I'll just explain that. So as there will be collection of the blood in the vagina, first it will lead to hematocolpus. After hematocolpus, it will go for hematometra. After hematometra, it will go for hematosalpinx. And then the blood will go into the pelvis and it will cause endometriosis. If the question also had symptoms like chronic pelvic pain and dysmenorrhea, right? So definitely, so probably there was a transverse vaginal septum which has been treated later where the woman when she started menstruating, because when there is a transverse vaginal septum she definitely can't menstruate, so they would have treated this transverse vaginal septum, because transverse vaginal septum will present to you with false primary amenorrhea, so you have to resect the transverse vaginal septum. But transverse vaginal septum definitely holds the risk for endometriosis. Whenever there is outflow tract obstruction like imperforate hymen, transverse vaginal septum, you have high risk for them landing up in endometriosis. So if how I will tell again this patient is gone to endometriosis is severe dysmenorrhea and chronic pelvic pain supports endometriosis. Okay. Right. So if you feel this, I want you people to post me this question. If some of you are disagreeing with this question, nothing, you can just post me what is the right question and we can discuss it. Okay. Next question. 28-year-old female, married 4 years back, anxious about conception, complaints of profuse vaginal discharge, no history of itching, 12 days since last menstrual period. So she is having she is infertile, definitely anxious about conception. She's having profuse vaginal discharge which has no itching, and it is around 12 days after her LMP. So that is the time of ovulation. Now trichomonas and candidiasis will be gone because they are associated with itching, and as it is just 12th day since LMP, so this is nothing but the physiological. So she is having ovulatory cycles. So she is having ovulatory cycles. Okay. So this will go for physiological. Okay, there was, I see some of you are telling me that there was one question, which is the most common uterine anomaly. Was there any question like this? Which is the most common uterine anomaly? So white discharge, no itching, profuse white colored vaginal discharge. White can be candidiasis also, but candidiasis may you'll have lot of pruritus, and this is very classical around the ovulation, right? 13th day or 12th day or 14th day, that is nothing but the ovulation. Okay, there was no such question, right? Okay, next. Okay, there was one more question. This female has missed OCPs on 4 different days in first and second week of menstrual cycle. What will be your advice? What will be your advice? There was no cardiac activity. All pregnancies had no cardiac activity. Can anybody post me this question correct? I want you people to see, some of you are writing normal cardiac activity, some of you are writing cardiac activity absent. That really confuses me. I want you people to post me 2 questions either in my Telegram group or personally on Messenger to me or anywhere. I want you people to post me this question as well as history of recurrent abortion, as well as there was one more question which this transverse vaginal septum question. These 2 questions I want you people to post me, guys. Okay. Okay, right. So this patient has missed almost 4 pills. This patient has missed almost 4 pills. Now this, I am 100% sure that because she has missed 4 pills, you all will tell that go for alternate method. But I have done one YouTube session where I have used the recent guidelines of the OCPs. If anybody, I don't know how many of you have gone through, but please go through this table again. So, according to the recent guidelines, when do you stop? It is very obvious for us that when we tell that 4 pills are missed, you have to go for stop that and go for alternate contraception. But this is one question I think some of you can go wrong based on the guidelines. If they miss more than 7 consecutive pills, then you have to go start a new contraception or alternate contraception. Okay. So 4 pills were missed at different times in last 2 weeks, right? So you see there is very clearly given about that criteria also. If she misses 2 to 7 pills in week 2 or in week 3, emergency contraception is not required. Take the most recent missed pill as soon as possible. Continue the remaining pill at the usual time. If 2 or more pills are missed in the 7 days prior to a scheduled hormone-free interval, omit the hormone-free interval. Alternate contraception, that is, condom should be used or sex should be avoided until pills taken 7 consecutive days. So they don't tell you to stop and go for other contraceptive. They'll ask you to use additional contraception along with the current pack if they are missing around 2 to 7 pills. So if you had such option, so in our patient, she has missed 4 pills in week 2 and 3. So continue taking the pill. Alone won't be the answer. Take all 4 pills and pills at once and continue the pill is also not correct. Adopt another method of contraception is also not correct. Continue the current pack. Consider additional contraceptive. If you had this option, then it will be the answer. So continue the current pack and consider additional contraception. Up to 7 pills also, if she miss, you can just continue the current pack and consider additional contraception. So consider emergency contraception if unprotected intercourse happens in the last 2 days was also given is what some of you have given me. Okay. Right. Second gravida pregnant with twins. Now what is the obstetric score was one more question. This is again a repeat, guys. So second gravida G2. Now she is pregnant with twins. Previously she was not pregnant with twins. So P1. And twins also will be always para 1 itself, not para 2. So it will be G2 P1. Okay. So those were, I hope I covered all the questions to all of you. And even if they had previous twins, then also your answer will go for G2P1 because twins is always para 1. Twins is always para 1, not para 2. Okay. So, carrots, you can send me the question of abortions, because if cardiac, some people have sent me that cardiac activity was present. Okay, there was one question on heparin. Anybody can tell me what is the question on the heparin? I missed the heparin question. So what is the heparin question? 36 weeks, pregnant on warfarin with mitral stenosis. What should we do? So at 36 weeks, you shift to low molecular weight heparin, right? So here the answer, if there was 36 weeks pregnant patient on warfarin with mitral stenosis, what is the further management? Shift to low molecular weight heparin. Shift to low molecular weight heparin. Now I'll just write for you all. This is also a repeat. Up to 13 weeks, you go for warfarin. Up to 13 weeks, you go for low molecular weight heparin because warfarin is teratogenic. 13 to 36 weeks, we go for warfarin. 36 weeks till delivery, you don't use warfarin post 36 weeks because warfarin has long half-life. So there is more chance of excessive bleeding and baby having intraventricular hemorrhages. So 36 weeks till delivery, you will go for low molecular weight heparin. Breastfeeding, that is postpartum when there is breastfeeding, you can again go for warfarin. Right? So options were switch to aspirin, aspirin plus heparin, heparin only. So you don't require aspirin here, and after 36 weeks, we don't give aspirin because aspirin also increases the bleeding. So you always use aspirin only till 36 weeks. So after 36 weeks, switch to heparin will be your answer. Switch to heparin will be your answer. Okay. Now I want you to send me 2 questions. One is that apla ya syphilis wala question and that endometrioma question. I want you people to send me. Okay. You will never give aspirin after 36 weeks. Right. So this missed pill table, I'll send you all. You can just go through it. Any further also, it will be useful for you all. Right. Now, So whenever 4 pills are missed, alternate, or whenever it is not an issue, but you don't shift to the other contraceptive or stop this contraceptive. You continue, take the most recent pill, continue the pills, use additional, that is, you can ask them to use the condom. If you had such option, you have to go for that option. I hope it is clear for all of you. Okay. Right. So there was a Sheehan syndrome question. Indomethacin causes what when given to a pregnant woman preterm? Very good. I think there is one question on indomethacin. So I am getting some more questions. Thank you guys. So there was one more question on indomethacin. Uh, one second. So indomethacin when given beyond 36 weeks, what will happen? So indomethacin given after 36 weeks, it will lead to premature closure of patent ductus arteriosus. So that's why we don't give. So it causes premature closure of patent ductus arteriosus. Right, there was, yes, indomethacin causes premature closure of patent ductus arteriosus. There was a question on Sheehan's. You can share me the questions on question on Sheehan. And one more question is on prolapse. Okay, so there is a patient with cystocele, and patient has a complaint of passage of urine on straining. If you remember, even when we do prolapse, the most common incontinence associated with prolapse is what? Urge incontinence or stress incontinence. Which incontinence? So it is stress incontinence, right? Most common incontinence associated with prolapse is stress incontinence, and there was a history of passage of urine on straining that also favors, and most common incontinence associated with prolapse is stress incontinence. Okay. There was one question on umbilical artery. So what does umbilical artery do? So what is the function of umbilical artery was another question. Excellent. It causes the So Zani has put forward the exact question. Second degree cervical prolapse complains of dribbling on cough. What is the type of incontinence? It is nothing but the stress incontinence. Next I have what is the function of umbilical artery? Function of umbilical artery is carrying the deoxygenated blood from the fetus to the placenta. Right? So I missed 1, 2, 3. There's one more question. That is, patient came with fatigue, had multiple transfusions in the last pregnancy, no period since then. What is the diagnosis? Excellent. So this is again amenorrhea always must, right? So patient with fatigue, multiple transfusions in past pregnancy is nothing but multiple transfusions in the past pregnancy is nothing but it is PPH. So patient has come to you with secondary amenorrhea. After that she never had menstruation, and probably if they would have given failure of lactation also, then that is nothing but the Sheehan's. So I think all of you are clear with the Sheehan's. So I think these are the questions which we missed out. So Sheehan's, cystocele का तो stress incontinence 100%. Indomethacin will cause premature closure of PDA. Umbilical artery, deoxygenated blood from the fetus to placenta, right? And warfarin at 36 weeks you have to shift to low molecular weight heparin. Now many of you have the confusion with choriocarcinoma. Please see this. This is the table. So low risk or high risk is not just decided by one condition. There is a WHO scoring system, guys, where if they get a score of more than 7 or score less than 7. Now, even if it is a score of low risk or high risk, it doesn't matter, because please see here, choriocarcinoma with lung mets goes for stage 3. Choriocarcinoma with lung mets goes for stage 3. Stage 2 or 3 FIGO, stage 2 or 3 FIGO. with low risk WHO score, that is less than 7, or high risk WHO score, which depends on many other conditions. Both of them, what is the answer given? Combination chemotherapy. What is the only thing which is going to change here, whether it is low risk or high risk based on the score, is plus whether you have to do hysterectomy or whether you should not do hysterectomy. But anyway, they didn't ask you so much complicated. They just asked whether you will give single agent chemo or whether you will give combination chemo. So please remember, single agent chemo is given only for stage 1 FIGO with low risk WHO. Only there you will give single agent chemo. Otherwise, in all other cases, you are going to go for combination chemotherapy itself. Okay? Right? Now, I'll do one thing. So, rifampicin, when patient is on rifampicin, you should never give OCPs because it will lead to the efficacy of the OCPs will reduce, because rifampicin will lead to increases the metabolism and breakdown of the OCPs. Right? Only hysterectomy was there in the option. Again, that won't be the answer because emaco regimen is the most important than just hysterectomy. Okay. Emaco is the answer. Combination chemo is nothing but the emaco. Okay. So ectopic, I think we have discussed based on what you have written, right? So I'll do one thing. Whatever questions you have put forward to me, I'll frame those, and again I'll write the answers and I'll try to post you in our Telegram groups so that you can go through it. Now don't think about what I think all of you have done great and most of you have answered all the questions correct, or one or two questions going wrong doesn't matter at all. So don't worry for one or two questions. Now whatever it is, just leave it. Just leave. I think you all deserve a proper break for 2 to 3 days at least, guys. So these 2 to 3 days, next 2 to 3 days, come out of all this and just enjoy, watch few movies, eat well, go out with your friends, whatever you have to do. If you have worked really hard, I can't tell you that you can plan to go to Goa or Thailand or anything, because now it's a COVID situation. But you all deserve whatever hard work you have done. You all deserve some break and you have to treat yourself. So this is a time where you have to treat yourself, because it was a lot of havoc this exam, like always getting cancelled, coming back, cancelled, coming back. So it was not easy. You have all done a great job. So take a proper break, enjoy, and all the best, guys. All my prayers with you all. You all will get a very good rank and a very good seat, your deserved seat. So be positive. That's most important, right? Thank you, guys. Thank you. Thank you, Lakshmi Prasad. So I've done the ectopic pregnancy. You can watch the video, Sangeeta.